Hi, everyone. My name is Gurjat Basra, and I'm the Manager of Patient Programs, Research and Advocacy at Lymphoma Canada. I'm pleased to welcome all of you to today's session on Hodgkin lymphoma. We appreciate those who have been able to join us live today to learn more about the disease-specific biology of this lymphoma subtype, as well as novel treatment options available for Canadians. Before I introduce the speaker, I just want to provide some guidance about the Zoom software for the session. So the virtual software does not allow you to share your video or turn on your microphone. Hence, if you have any questions, please save it for the Hodgkin lymphoma Q&A session that will follow this presentation. So without further ado, to introduce our speaker, today we have here Dr. Anka Prika, who is a staff hematologist at Princess Margaret Cancer Centre and associate professor in the Division of Hematology at the University of Toronto, appointed in 2014. She is currently the site lead of the Lymphoma and Myeloma program at Princess Margaret Cancer Centre. Her clinical work focuses in both lymphoproliferative and plasma cell disorders, as well as autologous stem cell transplantation and CAR-T therapy. Her research interests focus on health services research, particularly economic evaluations and decision analysis for oncologic questions, examining resource use and cost of care, as well as toxicity of chemotherapies and their effects on quality of life and caregiver burden. So thank you so much, Dr. Prika, for joining us today, and I'll hand it over to you.
Perfect. Thank you so much for having me and for that very kind introduction. And here's the title of my talk, Hodgkin lymphoma. We'll talk about some diagnosis, related issues, treatment, and a little bit on future research. Here are some of my disclosures. I've participated in some meetings by the companies here, just related to advice about some drugs they make, none of them related to Hodgkin lymphoma. I also have a disclaimer that I work at Princess Margaret Cancer Centre, where the people I work with hold strong views about the treatment of Hodgkin lymphoma, but the opinions presented here are my own. Thus, the objectives of this breakout session will be to review some of the biology of lymphoma in general, and then I'll focus on Hodgkin lymphoma specifically. I'll review some current treatment options and the use of modalities such as PET scanning to provide risk-adapted therapy. I'll talk about how new treatments are being incorporated into frontline therapy, and I'll just touch at the end on treatment options if the Hodgkin lymphoma relapses or comes back. To start with, a reminder of what the lymphatic system is, as we are talking about a cancer of the the system, and this really is a network made up of a number of components, including lymph nodes, of course, and we have many throughout our body, lymphatic vessels, but there are also organs that include the bone marrow, thymus gland, which is in our neck, tonsil, spleen, liver, and as well, there are some parts of our body, like the lining of the gut and the lungs, where lymphocyte cells could exist. And you can see there the picture on the right, highlighting some of these areas. What are lymphomas? They really are cancers that develop from the immune system cells, and they're cancers of the lymph nodes, which are mostly, again, the glands in our body, like in our neck or under our arms, but can also include the spleen and the bone marrow. And lymphomas, or cancers in general, can have a leukemic phase, which really just means that there's cancer cells in the blood. So if lymphoma cells are in the blood, they may have a designation of leukemia. So for example, a non-Hodgkin lymphoma that's designated as such as chronic lymphocytic leukemia. This problem is much rarer in Hodgkin lymphoma. Lymphoma is the fifth most common cancer. And in Canada, the incidence has been increasing over the decades. You can see here in the chart that there are about 9,000 new cases per year, with only a smaller proportion of those being Hodgkin lymphoma. And the other category that encompasses many different types of lymphomas, non-Hodgkin lymphoma, comprises of the majority of those patients. Thus, as I've alluded to, lymphoma does consist of more than 50 different types, most under the non-Hodgkin lymphoma category. The treatment really depends on the type of lymphoma, where it is located in the body, as well as the age and general health of the person that's dealing with this problem. But really, the type of lymphoma that one has is very important for determining the treatment approaches. And I've designated here a little bit of a chart just to show you how it breaks down. So again, there's Hodgkin and non-Hodgkin lymphoma. We're mostly talking about Hodgkin lymphoma today. You can see there's a fairly homogeneous group. There are some subtypes that I'll highlight, but overall, it's essentially the same lymphoma. But under the non-Hodgkin lymphoma categories, there are B and T cell lymphomas, and those can be further broken down into aggressive and indolent lymphomas with numerous subtypes under each of those categories. Thus, as I've shown already, Hodgkin lymphoma is a rarer type of lymphoma and occurs at about a fifth the frequency of non-Hodgkin lymphomas. There are a few different subtypes. The majority of Hodgkin lymphoma is designated as classical Hodgkin lymphoma, and under that, there are these four categories: nodular sclerosis, mixed cellularity, lymphocyte-rich, and lymphocyte-deplete. And really, this is a description based on how the lymphoma looks under the microscope. And the majority of cases are the nodular sclerosis subtype. It doesn't have a huge impact on the treatments we give, but they might come with a slightly different prognoses that we think about when we evaluate a person. There is a much smaller proportion of patients with a rarer subtype called nodular lymphocyte predominant that can behave more like a B-cell lymphoma, and that's about 5% of patients, and the treatments may be a little bit different for this subtype. So how do we diagnose lymphomas? Really, having a good amount of tissue is key for making sure we're dealing with the right subtype. As I've highlighted so far, there are many different types, and to be able to really tell what kind it is, the pathologists need to be able to see a good amount of tissue and to be able to see all the different characteristics and how the cells behave to make a proper diagnosis. And that's often can be with what's called a core needle biopsy, where a larger needle is used to take some pieces of lymph node, for example. But the best way to look at to try to make a diagnosis is through a surgical resection, so actually taking out a whole lymph node. For some other cancers, just doing what's called the fine needle aspiration, which is putting in a thinner needle and taking some a fluid sample or a liquid sample of the tissue, could be adequate for diagnosis or for some of the other solid tumor cancers, for example, but it's most of the time not enough for lymphoma diagnosis. Some of lymphomas can be diagnosed through a bone marrow aspirate biopsy, rarely, and sometimes in the peripheral blood with some of the non-Hodgkin lymphomas, but much less so for Hodgkin lymphoma. And why is pathology important? I think I've highlighted it a couple of times now. It's needed to really determine exactly what type we're dealing with so we can give the most appropriate therapy. And again, it can require large biopsy, so removal of a whole node is preferred. But sometimes if the area in question is in a tougher place to get to, like in the chest or in the abdomen, a needle core biopsy is the best we can do. And some of the criteria for diagnosis are very specific and lead to specific treatment choices, like looking for particular markers on the cells to determine the best treatment. And again, we can only do so if we have enough cells and enough tissue to be able to do that testing. Moving on, once we have a pathologic diagnosis, we need to stage the lymphoma, so figure out where in the body it is, and that can be done through physical examination, but most of that happens through imaging, which can be CAT scans of the head and neck, chest, and the abdomen, but also most of the time now in lymphoma paired with a PET scan, which is like a CAT scan, and they get done together, but a sugar solution is given that lights up where the lymphoma is, so it can give us a better representation of the distribution of lymphoma. And often PET scans are done at diagnosis and then at the end of therapy to assess the response to therapy. But in Hodgkin lymphoma, it's also used as an interim response after a couple of cycles of chemotherapy. And I'll talk about that in a little bit more detail when talking about treatments to help us determine the best course of treatment to continue on with. This is how lymphoma is staged. So you can see if it's just in one spot in one of the lymph nodes, that would be stage 1. If it's a couple of spots or a few, but they're either above or below the diaphragm, so staying in one half of the body, that would be stage 2. If there are lymph nodes above and below the diaphragm, it would be stage 3. And stage 4 is where there's involvement of other organs, such as the liver or the bone marrow. But all that to say, even if a patient has a stage 4 disease, the treatments we have can still be very effective and offer long-term remissions and a cure. It also matters whether the tumor is bulky, so whether it's a particular size, over 7 centimeters in the chest or 10 centimeters in the abdomen, give or take, depending on different guidelines. And we also ask or look at the presence or absence of what's described as B symptoms. So those would be symptoms that a patient is experiencing that are tell us that there's more active lymphoma. So that would be weight loss that's more than 10% of the body weight over the previous 6 months without dieting. So that this would be unintentional weight loss, unexplained fevers, as well as drenching night sweats. And those are the kind of night sweats that where people need to change their pajamas or change their sheets one or several times per night, and they're really sort of soaking through the whole body. And here's a picture of the PET scan I mentioned in terms of looking at diagnosis as well as response assessment. So you can see on the left before treatment, there's a number of black spots on this picture, which is a black and white picture. There's also a version of it where it's brighter and there are these bright yellow spots that show us where lymphoma is. And perhaps you can appreciate on the right, most of those black spots are gone, indicating a response to treatment. There are still some spots, and that's normal uptake by some of the parts of our body that take up sugar solution. So the brain at the top of the head there, because we're thinking a lot, and our heart, for example. And if you are seeing some PET scan reports, for example, as a patient or as a caregiver, you may see description of a point or number criteria, something that's described, for example, as Deauville 1 or Deauville 4. And this is really a description of the brightness of what's perceived to be the lymphoma areas or other such areas as relating to normal uptake in some tissues like our liver, for example. And that's how this gets marked. It's important to remember that brightness on PET scans doesn't always represent lymphoma. There, any kind of inflammation or other processes can lead to lighting up as well, and that's where radiologists can be very helpful in trying to determine for us whether it looks like it's a lymphoma or something else. What determines the outcome of treatment for lymphoma? As I mentioned, type of lymphoma, the age of the person going through treatment, their performance status, how well they're functioning. The stage is very important, and that's why a PET scan, for example, or doing full imaging is very key to determining what the best treatment approach is to, again, maximize the chance that we can get rid of it, the bulk of the disease, any extranodal disease, so having it in areas other than lymph nodes, and the treatments themselves that we give. And for different cancers and different lymphomas, there are studies have identified some variables that can be put together into a score to help determine the chance of doing well with chemotherapy. And in Hodgkin lymphoma, for example, if one has more advanced disease, so stage 3 or 4 disease, this is a score that can be used that adds together some blood parameters as well as some features of the person going through treatment. And the more variables that are present, the higher the probability that with treatment, or the chance that at the end of treatment, we might not have been as successful as we'd like to be at getting rid of the lymphoma. But even if the score is high, the chance of treating it successfully is still reasonably high and worth starting out with the treatments that are felt to be the best in front line. So now that we've talked a bit about diagnosis and how we stage patients and some of the variables we think about in terms of risk, let's talk about Hodgkin lymphoma overall and what the treatment options are. First of all, we can see that Hodgkin lymphoma really is more of a lymphoma of younger people with peak diagnosis between the age of about 15 or so, 14 to 15 to about 45. And but there is a second peak for people as they age more into the 65 to 75 range. However, overall, the median age of those diagnosed with Hodgkin lymphoma is about 37 years of age, which is significantly younger than most other lymphomas, where the median age is about 60 to 70. So how do we treat Hodgkin lymphoma? First of all, before I talk about some of the options and the studies that support these treatments, there are some definitions to think about. When we look at the outcomes of treatments, we might talk about response rates. So that means how successful we were at getting rid of lymphoma as best as we can tell on imaging, usually. So PET scans at the end of treatment. And a complete response would be that we believe all the lymphoma is gone, and a partial response is where more than 50% of the lymphoma volume has disappeared. Most of the time these days, that should be done with a PET scan along with a CAT scan, not just a CAT scan alone. And as I previously showed you, the Deauville score is a way to quantify how much uptake is left in the lymph nodes compared to surrounding tissues at the end of treatment. And a score of 1 to 3 represents a complete response, where we feel quite confident that we've gotten rid of most, if not all, of the lymphoma. A Deauville 4 would be a partial response, and a Deauville 5 is where, unfortunately, there's still enough brightness that we're concerned there's no response or sometimes progression of the lymphoma. A lot of trials use progression-free survival as an outcome or as the main outcome that they discuss. And this is really a measure of cancer or lymphoma control. So though it has the word survival in it, it's really the length of time from starting treatment until the disease starts to grow again if there is a relapse. And this is comparing to overall survival, which mostly describes the chance of being alive for the longer term, and it's measured as the time from start of treatment to dying or passing away from any cause, and that could be lymphoma, toxicity, or if people are older, other old age diseases. Before I talk about the modern treatment approaches we take, it's interesting to think back to Hodgkin's lymphoma or Hodgkin's disease. Another way of describing it has been around for a long time as a recognized cancer. And there's actually data back on the left. We can see back in 1940, a publication of what the outcome of patients that were not treated with any therapies was. and that's the triangles, and then the line with the circles were patients in the 60s who had single agent chemotherapy, essentially. And we can see that by about 5 years, unfortunately, in that era, most people would have passed away from this cancer. And on the right, we can see the outcome of patients over the last 40 years or so, perhaps even longer, 50 years or so, and also by age. And we can see it's been the survival of Hodgkin lymphoma patients has been improving nicely through the last number of decades, and particularly in the last decade, the purple line on the top shows us that certainly for those in that higher peak in the younger age category, the survival is over probably 90 to 95%, and so excellent, and just dips down a little bit more for older patients, and that's for a variety of reasons still. So what are some chemotherapy regimens that can be offered for treatment of Hodgkin lymphoma? And I won't go through this in detail, it's just to highlight, if of interest, some of the chemotherapy, drugs, and doses used. But the key parts to highlight is that the recipe called ABVD has been a standard in North America for many years, and it's essentially a combination of 4 intravenous drugs that are given every 2 weeks. A newer version incorporates a novel agent, brentuximab vedotin, that I'll talk about in a few slides, into this recipe, substituting for bleomycin, one of the chemotherapies that can cause lung toxicity, and that's been shown to be very efficacious. And in some jurisdictions, and particularly in Germany, where this is the preferred treatment option for, especially for advanced stage Hodgkin lymphoma patients or those with the bulky disease and other more high-risk features, a recipe called escalated BioCop is preferred. And this is essentially a more intensified chemotherapy regimen that is very efficacious, but comes with some extra toxicities to balance when considering the options. When comparing data on different regimens and different treatment approaches, to take a step back, this is how data can be presented, and how oncologists or doctors look at data and trying to decide if one treatment is better than another, for example. And on the y-axis, you can see these are called Kaplan-Meier curves, and in essentially most studies that present the outcomes of patients over time, whether it's overall survival or progression-free survival. On the y-axis, we can see the percentage of patients who are alive or in remission, for example, and on the x-axis at the bottom, the time from end of treatment. And usually if you're comparing two regimens, for example, or to treatment options, you might see 2 different curves like the ones here. And the important question that we have to ask ourselves, if there is a separation between the 2 curves, is that difference between them significant? Is that worthwhile adopting, let's say, the treatment on top, which is the solid purple line, over the treatment on the bottom, that's the dashed lines? Because often there may be different toxicities, for example, that come with the 2 treatments, if you're getting some extra efficacy from the treatment on top. It's also important to remember a remission doesn't necessarily, unfortunately, equal a cure. And remission, we talk about usually at the end of treatment, when we've done the imaging and think that we've gotten rid of all the cancer, so it's a state of being. However, to think that we've cured a lymphoma or a cancer does require a little bit longer follow-up, usually at least 5 to 10 years of follow-up, to really confirm that the lymphoma isn't going to come back. There's also been some learning about biology of Hodgkin lymphoma that has led to new treatments. And this is related to the behavior of the cells that we believe are the Hodgkin cells. So the circled cell in the middle there is a Reed-Sternberg cell. Some people say it looks like owl eyes, and very typical of Hodgkin lymphoma. And you can see that it's this big cell that's surrounded by a bunch of other small cells that are inflammatory cells in the lymph node, or other parts of the lymph node that are essentially kind of surrounding the Hodgkin lymphoma cell. So 2 drugs that have been developed to specifically target that Hodgkin lymphoma cell, rather than, necessarily giving chemotherapy that just kills good and bad cells, which has been how traditionally we've treated many cancers, including lymphoma. And one such targeted drug is brentuximab vedotin. Reed-Sternberg cells, the ones I just showed you, have a protein on their surface called CD30. And what this drug does is it's essentially a protein, an antibody that targets that CD30 protein and has attached to it a little bit of chemotherapy. And when that antibody attaches to the Hodgkin lymphoma cell, it's kind of swallowed inside by the cell, and then releases this bit of chemotherapy right inside the cell, and leads to cell death. Another mechanism through which treatment has been developed is to target the immune system specifically. And we know that cancer, just like other foreign parts of our body, have abnormal proteins that sit on the surface or leak out of cancer cells, and our own immune system cells, the T cells, which are really the soldiers of the immune system, should be alerted to the presence of these abnormal proteins, travel to the site of the tumor or the problem essentially in our body, and attack that tumor so that it can get killed. And why does that not happen well enough in all cancers, including in Hodgkin lymphoma cells? That's because the Hodgkin cells, those Reed-Sternberg cells I mentioned, have figured out ways to protect themselves from the person's immune system cells. So cancer is very tricky that way. So they find some other. So there are T cells that are surrounding these cells, as we can see there. However, there are mechanisms in how these cells interact, and this is perhaps a bit more details than we necessarily want to think about. But overall, the idea being that there are these interactions, the PD-1, which is an off switch for the interaction between the soldier cell and the tumor, and keeps the T cell from killing the tumor. And as well, these Reed-Sternberg cells have expressed some extra proteins to prevent the T cells from attacking them, and this is what's described as immune evasion. And as such, drugs have been developed to target this problem, this off switch, and the protein expression that keeps the T cells from attacking the tumor. And these are called PD-1 inhibitors or PD-L1 inhibitors. And when these drugs are applied, they prevent the T cells from being exhausted and restore that anti-tumor activity. And this has been a very successful treatment approach in Hodgkin lymphoma. So now that I've described some of those mechanisms, let's go on and talk about what are the treatment options available overall for Hodgkin lymphoma and to Canadians. So prior to having more knowledge and more use of PET scans, and as well having some of these novel agents like brentuximab and PD-1 inhibitors, the treatment of Hodgkin lymphoma was fairly straightforward. So if you had stage 1 or 2 disease, you usually have a few cycles of ABVD chemotherapy for the large part in North America, and have some radiation afterwards, which is a useful treatment for Hodgkin lymphoma. And if you had more advanced stage disease, such as stage 3 or 4, usually you would have mostly chemotherapy alone, and that was largely ABVD chemotherapy for more cycles, so usually about 6 cycles of chemotherapy, and perhaps some radiation at the end if needed. And with this approach, the long-term remission rate was very high, even for, and remains very high, even for those with more advanced stage disease. However, there are a proportion of patients with more stage 3 or 4 disease that still do relapse or the lymphoma comes back. So we're looking for ways to improve those numbers further. And in some of the earlier stage patients, toxicity from things like radiation, for example, when the outcome is so good, is also a concern. And that's been the balance that's been discussed in Hodgkin lymphoma and has been studied in many trials of giving more treatment that gives better disease control but may have increased long-term complications versus giving less treatment, as again, we're often treating younger patients that have many years of life to live, and that could risk a little bit higher relapse rates but may lead to less long-term toxicities. Thus, the question has been over time, can we maintain or improve remission rates and reduce long-term toxicity from treatment with some of our studies or some of the approaches we're taking? And the longer-term toxicities we often worry about would be cardiovascular disease, so impact on the heart, other cancers, and infertility from the chemotherapies we give. And so one way that treatment has improved or that approach has changed over time and is an approach we take now is to use what's called the PET-guided approach. So the idea is to do a couple of cycles of chemotherapy and then do a PET scan, which has been shown to be very helpful in telling us after a couple of cycles how well the person is going to do. And we know that if your PET scan is negative after 2 cycles, the outcome is going to be likely going to be very, very good. And as such, we can study reducing the amount of treatment we give. And if a PET scan is positive, the outcome or the recurrence rate is higher than we'd like it to be, even up to 50% or more. And as such, it's worthwhile considering intensifying treatment at that stage. So considering those approaches and different studies that have been done, looking at these approaches over time, how do we think about treating patients in 2023? Again, we divide the categories by stage. So we have limited stage Hodgkin lymphoma patients that would be usually stage 1 or 2. And the favored approach would be to start with 2 cycles of ABVD and then do a PET scan. And if the PET scan is negative, then we could give a little bit more chemotherapy and radiation, or just give some chemotherapy and omit the radiation. And those discussions are often, or that decision making is based on the site of the lymphoma, how much there is, how close it is to the heart, and things like that. And if the PET scan is positive, we think about escalating or intensifying treatment to escalating BIACOP, that more intense recipe I talked about, and giving some radiation. And the favorable and unfavorable designations refer to some extra clinical features that are collected at diagnosis that help differentiate those categories for people. And the progression-free survival that I described as an outcome before is generally very high with this approach, more than 90% for the long term. What about advanced stage patients? So this would be those that have stage 3 or 4 disease, or sometimes stage 2, but with a lot of with a bulky mass or some of those B symptoms. And there's been numerous or a number of treatment approaches studied, but that we can think about. And one is to start with a more intensive recipe, escalate BIACOP, and de-escalate if the PET scan is negative after 2 cycles. And that's been shown to be to give a very good progression-free survival of at least 90%. In Canada, brentuximab vedotin is approved for stage 4 disease, and this can be given with AVD for 6 cycles. And there's no interim PET scan part of that treatment approach. Or we can start with ABVD and escalate therapy only if the PET scan is positive after 2. And you can see that the progression-free survival is a little bit lower with these approaches, but the toxicity might be a little bit less as well. And that's often part of the discussion in making a decision as to which treatment to choose. Radiation therapy, as I mentioned, is also very helpful in Hodgkin lymphoma, and it largely applies to localized disease. So if there's stage 1 or 2 disease after chemotherapy, it's generally given daily for 4 weeks, Monday to Friday would be an example, and that would be 20 treatments. And the side effects are generally related to the area that's being radiated, so kind of localized side effects. And we're thinking about, again, some of these different approaches and what it means for late effects or side effects. There are, or over time, there have been some worrisome late effects that sometimes have dominated the discussion, but a lot of those were based on chemotherapies and radiation fields that are not used as much anymore. So when thinking about things like secondary cancers, impact on the heart, or risk of acute leukemia, for example, from chemotherapy, with the newer approaches we have, the radiation is much better targeting with different techniques. So things like the breast cancer risk are significantly less, and perhaps not even higher than without radiation. Lung and heart toxicity from chemotherapy is uncommon, but we monitor very closely for it. And the risk of other cancers, including leukemia risk, is really low with the current approaches. However, of course, there's ongoing interest in incorporating these novel agents and perhaps decreasing the toxicity of chemotherapy. And so I'll just highlight 2 newer studies that were actually just presented in the last 6 months or so that may change our practice over time. And the first is a comparison of the brentuximab AVD approach that I talked about to adding actually nivolumab, which is the PD-1 inhibitor. So the immunotherapy I described when I was talking about the biology of Hodgkin lymphoma and how the cells evade the immune system and how to reverse some of that. So this is one of the drugs that does this, and it's very active in Hodgkin lymphoma. So now the idea was to test it in frontline in patients with stage 3 and 4 disease. So this was a study that compared 6 cycles of these two different regimens. And the data is very early, but after 1 year of follow-up, which is we would consider interesting, but we would like to see a little bit longer follow-up before changing practice. But it does appear that adding this PD-1 inhibitor, the nivolumab, improved the progression-free survival. So the chance that at 1 year people were still in remission by about 8%, which could be quite significant. Another approach that has been studied recently is by the German Hodgkin Study Group. They're the group that I mentioned use a lot of that intensified recipe, the escalated BIACOP. And they're looking to improve the toxicity of this regimen, but also and make sure it's still as efficacious as before. So they made some changes to the recipe that I just highlight if of interest, and certainly could be discussed further. But essentially, they're giving some lesser amounts of chemotherapy that could make the toxicity better, but also adding in that drug brentuximab vedotin. The advantage to again, the way they approach it is that if you start with this more intense recipe and after 2 cycles you're PET negative, you can, they have shown that you can then just have 2 more cycles of treatment and be done. And that's on average about 3 months of treatment, as it's a treatment given every 3 weeks. So from a time perspective can be very attractive, especially to our younger patients and to those that are trying to, want to get back to their life activities as soon as possible. And in this study, they demonstrated that progression-free survival, that chance of keeping the disease away for as long as possible, was excellent at about 95% with this recipe, probably the best we've seen in these more advanced stage patients. And the toxicity was better, so there was less low blood counts, and also patients needed less transfusions. So when I've shown you such data, and that does look perhaps encouraging or promising with newer treatments, we may wonder, when does a new treatment become standard? And that usually does require what's called a randomized phase 3 trial showing a significant improvement in an important measure, such as a survival time to progression, or some significantly reduced toxicity with long enough follow-up that we're comfortable with the results. And usually that's at least 3 years. So perhaps the last study we saw might be meeting that benchmark. The first one, adding nivolumab, might require a little bit more follow-up before that treatment can be adopted. And sometimes we can get drugs approved or take them up from phase 2 data. So that's usually where there isn't a comparison between two studies. But if the response rates or the outcomes look very good, perhaps in a more rare setting, like in the relapse setting, and there are no other approved drugs, that may be good enough data to think that a drug is worth using. However, in Canada, there are a few more steps. Once a study demonstrates good activity of a drug, and these are regulatory and rigorous processes for reviewing the drugs to make sure that they're safe and efficacious and good value for money for Canadians. So there's a Health Canada application and approval. That's the regulatory body that oversees drugs and technologies in Canada. There is a national drug review through an agency called CADTH that reviews the drug again for safety, efficacy, and its cost effectiveness. Then there is a national negotiating process between the healthcare agencies and the company. Then because healthcare is provincial in Canada, it goes to the provincial agencies for evaluation, in our case, Cancer Care Ontario, and then in Ontario, in our province, and then there is the Regional Cancer Center implementation. So a number of steps that can take some time, and there are negatives and positives to these processes. So finally, in the last 2 minutes, what happens if Hodgkin lymphoma recurs or if there's a relapse? For younger patients, even with our newer treatments, we believe that a stem cell transplantation is still considered the best option, and that's usually using autologous stem cells, so the patient's own rather than a donor. It does use very high doses of chemotherapy to try to eliminate resistant lymphoma cells, and it really is only beneficial if the lymphoma responds to another chemotherapy regimen than was given in the front line, and there are a couple of recipes that are used in Canada. And usually the long-term remission rate with this approach, when the lymphoma has shown itself to be a bit more stubborn, is about 50%. If the autologous stem cell transplant approach doesn't, again, work as well as we'd like it to work, depending on what treatments were given in the front line, the drugs I mentioned, like brentuximab vedotin, can be very active in the relapse setting, and it's usually given every 3 weeks for about 16 doses. And the PD-1 antibodies, I mentioned nivolumab, and another option is pembrolizumab, and both of these drugs have been shown to have good activity in patients when the disease has relapsed. And my final slide is to mention that there is a lot of interest in figuring out if these drugs, brentuximab, pembrolizumab, nivolumab, would make better options for salvage chemotherapy after one line of therapy compared to regular chemotherapy. And we have a Canadian trial that's running through our Canadian Cancer Trials Group. It has the designation of HD11 that is comparing these two approaches, chemotherapy to the novel agent brentuximab and pembrolizumab, as that is really the best way for us to figure out if a newer approach is better, the same, or worse, with perhaps different toxicities or not as much activity when comparing the two, although overall we think it's going to be probably equivalent treatments, if not better. But we again can only best evaluate this by studying it in a trial, and then based on responses, patients do go on to have a stem cell transplant or have other therapies. So this trial is open at a number of centers through Canada, and I think will be a good option for our patients. So I'm going to stop there. Thank you very much for your time. If there are any questions, I look forward to hearing them in the Q&A session, or of course any other issues that I did not address in this talk, I'd be happy to discuss. Thank you for your time.
Thank you, Dr. Prika, for that wonderful presentation. We appreciate your thorough review regarding disease biology and treatment options for Canadians. Now I'd like to direct the audience to attend the Hodgkin Lymphoma Q&A session after this presentation to have your questions answered live. Thank you, everyone.